All right, everybody. Just want to go ahead and do a quick welcome for everyone who is joining us. We're just 5 minutes away from starting. A couple logistics before we get started. I want to make sure that everybody who is joining can see the chat. If not, it's in the upper right-hand corner of your guys' screen. So you want to go ahead and just make sure that you are viewing that, just because we will be having some conversations and opening up to a chat for some of our presentations. But other than that, we are just 5 minutes away from getting started, and we look forward to it. So we'll get started here soon. All right, everybody. Good morning and welcome to SCNM, Southwest College of Naturopathic Medicine's Research Webinar 2019. We're going to go ahead and get started. Now, we are expecting both or all of these presentations, there's a total of 4 of them, to last about 25 minutes. After each presentation, we do ask that if you guys do have any questions, go ahead and write them in the chat, but we will be answering those questions at the end of the presentation, just to respect the presenter. All right, but a couple of ground rules along with, perfect. Now our presentation lineup includes Dr. Williams, Dr. Rodriguez, Dr. Tapia, and then Dr. Salisbury, which is going to be super exciting. Up first, we have Dr. Williams, who will be talking about some pretty cool stuff. But again, as always, just make sure that we are holding all of our questions until after that presentation, just so we can go ahead and really have that really cool conversation together. Otherwise, I'm going to go ahead and turn it over to our first presenter, Dr. Williams.
Hi, everyone. Good speaking with y'all today. So today I'm going to be talking about naturopathic interventions in primary dysmenorrhea. The first part of this is probably going to be a review for a lot of y'all, but I'm going to go over some conventional treatments, just an overview of what dysmenorrhea primary versus secondary is. Then I'm going to focus a little bit more on lifestyle and dietary interventions first, because I think that's something that we often give a lot of lip service to our patients, but we probably should focus on a little bit more, especially since the research really supports this as a method to help decrease menstrual pain. Then I'm going to talk about developing an acute botanical formula, and I actually have 2 specific formulas in this presentation that you can utilize with your patients going out the door today. And then I also have some supplement research, fish oils, B1, vitamin E, stuff like that to talk about a little bit further. I am going to provide all of these slides with you so that you can reference them later. So first up, this is just a slide overviewing. The ultimate goal of this is so that participants are able to integrate all the material that we discussed today so that you can assess and effectively treat primary dysmenorrhea in your clinical practice. So the difference, primary dysmenorrhea is referred to as the presence of recurrent, crampy, lower abdominal pain occurring during menses and in the absence of demonstrable disease, versus secondary, which is women that do not respond to conventional treatment like oral contraceptive pills or NSAIDs, and then other investigation in regards to the secondary cause is done. So common causes that would cause secondary dysmenorrhea would be endometriosis, uterine fibroids, pelvic adhesions, uterine polyps, and then I have a couple slides later where I discuss this a little bit further, and then appropriate workup to do after that. So obviously with primary dysmenorrhea, you're just going to want to do basic lab tests and imaging, basic HPI and PE. You don't necessarily need to do lab tests or imaging at this time, so long as you try basic treatments and see how they respond. Again, if they still don't respond to treatment, whether that's conventional or naturopathic, that's when you need to start doing additional investigation. So this slide, again, don't worry about writing any of this down. I'm going to give you this slide. But patients that are refractory to primary dysmenorrhea treatments, you're going to want to do further workup. And this kind of just lists various different causes, appropriate imaging to do, and then any appropriate lab tests. And then just a general note about doing a menorrhagia panel on any of your patients that have any significant uterine bleeding. So basic screening blood work, you could consider adding red blood cell magnesium to the blood work, B vitamins, vitamin D, iron panel, and then consider clotting panels. So this is one of the panels that I typically do through LabCorp for any patients that have pretty significant uterine bleeding. So in regards to conventional treatment, I have a couple slides later basically citing ACOG and UpToDate, which is what I took most of this information from. But even they recommend before starting any sort of drug therapies or more aggressive therapies to first work toward weight loss, exercise, applications of heat, yoga, and sexual activity, all to decrease menstrual pain. So this is something that both us as naturopaths and then the traditional allopathic doctors are going to be focusing on with the patients first, because this is going to help decrease menstrual pain overall. And then these are typical oral contraceptive pills that they typically recommend in the event that all of those before drug treatments don't work. So this is NSAIDs. I just gave a typical recommendation dose from UpToDate. And then there's just a theoretical concern of patients that are on NSAIDs for anybody treating fertility patients, that NSAIDs can impair ovulation because they act as COX-2 inhibitors, which decreases prostaglandin production, which is needed to stimulate ovulation. So just something to be mindful of if they're taking it an exceptional amount throughout their menstrual cycle. So toxolytics would be another thing used conventionally. And in this case, they're basically using different forms of drugs that help decrease uterine spasm. But naturopathically, we can use a lot of different herbal treatments that do the same thing with pretty good effects. And this is just the resources, which y'all can reference if you'd like to read up more on this in conventional treatments. So naturopathically, there's so much that we can do to help these patients with primary dysmenorrhea. So this is kind of just general treatments that most of y'all are probably familiar with. So a diet limiting red meat, switching to range-fed or grass-fed meat, an anti-inflammatory diet, so they're decreasing those pro-inflammatory markers, foods rich in magnesium, so they're improving vasodilation, decreasing uterine spasm, and then fish, which is shown to decrease prostaglandin synthesis in general. Lifestyle management, I have a couple research articles on Zumba, and then just various aerobic exercise that has been shown to have really good results with decreasing menstrual pain. And then stress management is another thing that we talk to patients about, but we really need to make sure that they're incorporating it into their lifestyle, not only for decreasing menstrual pain, but just general support for other possible things going on in their life. So here's a study on mice that were actually fed various types of diets. Some were fed grain-finished bison, some were fed range-fed beef, others were fed feedlot steers, free-range elk, and chicken breast. And then after the mice were fed this diet for an extended period of time, they were then harvested, the macrophages from the peritoneum, so that they could be studied for the amount of prostaglandins that were produced, which of course are potent inflammatory mediators that go on to be associated with menstrual pain. And they found that the lowest production was found in mice that were fed range-fed beef or range-fed bison and then elk, and then the highest amounts of prostaglandins were found in grain-finished beef and chicken. So just something to keep in mind as you're making dietary recommendations to your patients. So here's a study on exercise and Zumba. And basically, they divided patients into two different groups. One group was told to do Zumba 60 minutes 2 times per week. The other group was told to do nothing at all. They were checked in 4 weeks and 8 weeks, and they found, unsurprisingly, that when patients incorporated Zumba, a form of aerobic exercise, there was significant reduction in menstrual pain. So one exercise, if your patients like Zumba, to definitely incorporate in. This is another study that didn't really give specifics on the type of aerobic exercise, but they had an experimental group where they were advised for 4 weeks, specifically in the study on how to do aerobic training, and then they were kind of let loose for 6 months to do their home aerobic training, and then they had a control group that basically wasn't given any advice or recommended any sort of aerobic interventions. And then the findings after 4 week checked in, they found that there was significant reduction in the quality and intensity of the pain, and then they were followed up after 6 months, and in 7 months, they still had a significant reduction in their pain, having incorporated in aerobic exercise. This is a study that's more so extrapolating out how progesterone can be decreasing menstrual pain, but it basically was a non-randomized controlled pilot study that found they basically examined various inflammatory markers related to menstrual pain, and they found that when patients incorporated aerobic exercise into their lifestyle, they had an increase in progesterone and a decrease in inflammatory markers like TNF-alpha. And then the researchers theorized to progesterone basically helped reduce menstrual pain, having increased during this time. Lastly, before we get on to talking about an acute botanical formulation, is just stress relief and for mental health. And then unsurprisingly, patients that had more work-related stress resulted in increased reports of menstrual pain. And then patients that had better stress management also had decreased menstrual pain. So now I'm going to chat a little bit about specific botanical interventions and specifically how to make a tincture for your patients. It's one thing that I'm pretty passionate about, making your own unique formula for your patients. So first off, a couple actions to consider. So if we're dosing acutely, these are going to be actions that we're going to focus on, and we're not really going to be focusing on hormone modulation, because that's going to be something that they would be on more long-term, versus this is going to be a formula that they're going to take for a couple days while they're having active pain. So main actions are going to be spasmolytics, anodyne, analgesics, pelvic lymphagogues would be definitely something to incorporate in, and then COX inhibitors. Other considerations would be nervines, styptics, or astringents for the patients that have heavy bleeding, the nervines where maybe they have a more anxious component, more stressed out during their menstrual cycle. I will say that some of the herbs that I am talking about, this is not an exhaustive list, and there's definitely other herbs that you can use. I just wanted to give some examples. So over here, I have a long list of various spasmolytics that you can utilize. I'm going to talk about a couple of them just so you can kind of get an idea of different research that supports their analgesic capacity, as well as why use them in your formulas. And then a couple notes about safety, because some of these herbs are lower dose, but I don't want y'all to be afraid of using lower dose herbs. You just need to use them safely to be effective. So some anodynes and analgesics. A common pelvic lymphagogue that I don't think a lot of students learn is going to be Foquaria. And then other things not listed. So some styptic examples would be like geranium, quercus, cinnamomum, and then some nervines. Actea is up there, but Actea can be used both for spasmolytic as well as a nervine. Leonoris, Melissa, and Bacopa would all be things to kind of consider. So this is just a quick review of a couple herbs that's on those lists. So Corydalis is going to be an herb traditionally used in traditional Chinese medicine to promote circulation of blood and qi. Most of these herbs that I'm going to be talking about are pretty bitter. So that's one thing to kind of keep in mind when you're making these formulas for patients. Sometimes these patients are in so much pain, they don't really care whether the tincture tastes bitter or not. But, if they really, really don't like the taste of certain things, probably something to keep in mind. So Corydalis in particular has THP, which is an active constituent that's been shown to have analgesic effects. Here's the research study that supports that a little bit further if you want to look into it. The main actions of this herb is going to be anodyne, sedative, and spasmolytic. And it's not necessarily a low dose herb, but you just kind of need to be mindful of dose. So the max amount would be 6 mils per day. And all of the examples that I've given you, I've done the math on them. And then when you get the slides, you'll see the math that I've done if you need a reference point. So pulsatilla is another one that's really great for menstrual pain, and definitely something not to be afraid of using, just be mindful of it. So constituents would be the ranunculin, which is in the fresh plant, which is what's not commonly used and actually recommended that we don't use. And then the anemonin, which is the active constituent in the dried plant. And there's a lot of studies on anemonin, one of which that I found showed that anemonin containing plants were shown to decrease interleukin-1 and NF-kappa B pathways that were active in osteoarthritis, therefore decreasing significant amounts of pain. So basically the researchers theorized that by decreasing the inflammatory response, understandably, it decreased the pain. We can kind of extrapolate that out from there. Again, this one's also really bitter. It is a more cooling herb, so that's something to keep in mind. The actions are pretty much the same as Corydalis. I have the low dose herb dosing on here. Of course, you want to make sure that you check the ratios. This is a 1:10 ratio. Significant side effects would be burning of the mouth, violent gastritis, irritation of the kidney and the urinary tract. And then these are the contraindications. Of course, just be mindful, reference your monographs, make sure that you're being safe. So Pisidia is another herb that I commonly use in these formulas. Lots of studies on its active constituent, rotenone, hopefully I pronounced that one correctly. And they've been studied for different types of neuropathic pain. Lots and lots of research out on that one. And then this one also is a 6 ml max dosing. So valeriana, just a reminder that this is not just an herb that you have to use for sleep or anxiety. There's a lot more to it than that. So one research study that I found showed that it has inhibitory effects on the contractility of the uterus. Therefore, it's definitely something that we can use in dysmenorrhea. And I will say a lot of the combo encapsulated formulas do have this herb in there, which is really good to keep in mind. Also has some of that anxiolytic action to kind of help calm patients if they're feeling a little bit more anxious during their menstrual cycle. This one's also really safe, 15 ml max. So just a couple reminders, I chatted about some of this earlier, but when you're formulating acutely, you don't want to use hormone modulators because they're not going to be helpful acutely. Don't be afraid to dose high. Make sure you just review the max dosing and that you're also dosing at a therapeutic level. If the max dosing is 90 drops and you're only giving them 10 drops in the formula, it might not be best to even use that herb because you're not even kind of touching the level that would benefit the patient. You may need to dose the patient a little bit more often at the start of their menstrual cycle when their pain first starts, if that's kind of when they usually have that type of symptom, just to kind of help it build up into the serum, and then you can kind of decrease it from there. And then also consider the energetics, the tastes, synergizers, overlapping actions. This is something that you can kind of think on and add after you've kind of worked on your main herbs that you'd like to add. So here's an example of one of the patients that I've worked with, 29-year-old female with 7 out of 10 menstrual pain. First 2 days of the menstrual cycle, flows relatively light. They have mild anxiety and stress before and during the menstrual cycle. They have sharp spasming pains, and then with the formula that I'm going to talk about, they decreased their menstrual pain to a 2 out of 10. So that's pretty good. So for the mild anxiety and stress, I kind of wanted to think about adding in a nervine or anxiolytic type herb. For the sharp spasming pain, obviously a spasmolytic or an anodyne. And then a pelvic lymphagogue I always found to be really helpful in these types of formulas. So this formula definitely changed the name to something a little bit more exciting than sample tincture 1. But there's various herbs that I've kind of already gone over, the Corydalis, the Piper, the Pisidia. Piper I added in there, also a really strong spasmolytic. Over at the SCNM Medicinary, we have it in glycerate form, so it can make the tincture taste a little bit better. The Passiflora, really mild spasmolytic action, but I use this one a little bit more for the anxiety and the nervousness that the patient experienced, as well as it having glycerate. And then the Glyceriza is a synergizer, so kind of just synergized all the herbs together. It's also a corrigent, so I tried to make it a little bit better given how bitter this formula is going to taste. So what I typically recommend is that a patient would try this and then they dose it the 3 ml every hour up to 9 doses per day. So that max would be 27. And that's a really safe dose. I'm kind of bordering on that 6 ml for the Corydalis or the Pisidia, but I could definitely dose it even more. So this is just room for improvement. Patient tries the tincture. Maybe your patient says that their pain decreased to 5 out of 10 or maybe 3 out of 10, then you can kind of know or maybe they describe their pain a little bit differently, and then you can kind of change the formula from there. Maybe they need a stronger spasmolytic, maybe they need more synergizers or more anxiolytic action, stuff like that. So this is another case of another patient that is 26-year-old female with endometriosis. They reported significant pain during menses that they rated 8 out of 10 with nausea, occasional vomiting, and then sometimes unable to work due to debilitating pain. They tried various medications to manage the pain with little change overall, and the patient usually feels really cold, their hands are cold, their feet are cold. And then with this formula, the pain decreased to a 3 to 4 out of 10. So not completely gone, but I will take it considering they've tried a lot of drug therapies in the past. So with this formula, I actually ended up putting pulsatilla in it. And when you get these slides, you'll see the math and how I calculated that. But this patient actually is around 40 drops of pulsatilla per day if they use the max dosing of 27 dropables per day. So I could dose it a little bit higher, but this is a really thin-framed woman, petite, so I just didn't want to go too high to start with and kind of see how they responded, so that I always had room for improvement of increasing the pulsatilla even more if I wanted to. You can see that this is a very warming tincture. Not all patients are going to be able to tolerate cinnamon and gingerbread and something like this, but this patient just really responded well to it. I don't think I have anything else to add on this one, but again, the 3 mils every hour, up to 9 doses per day. So this is all in your monographs, but just some general reminders, just be mindful. Some of these herbs basically affect the central nervous system, so we need to be mindful about CNS depression, but that's going to be an exceptionally high dose, which is not the way that you're going to be prescribing these formulas. So just make sure the patients know to take the formula as prescribed. I will say some patients that tend to have lower blood pressure, you just want to be mindful of giving some of these herbs that can decrease their blood pressure even more. So just make sure that you watch out for that. You know, if they run like 90 over 50 and maybe just are always low in office, you might want to consider just some other options, which we're definitely going to talk about. But I haven't really had too many issues so long as I'm mindful of how high I'm dosing things. Just a quick note about long-term herbal treatments. You can definitely consider your uterine and pelvic tonics. So rubus, michela, leonoris, and stuff like that, which we'll talk about a little bit later. I'm going to go a little bit faster because I think I only have about 5 minutes. So pycnogenol, this is some studies on pycnogenol that basically showed women on oral contraceptives also given 100 milligrams of pycnogenol daily showed a significant reduction in their menstrual pain beyond what the oral contraceptives were able to do. And then I also have another study that shows that pycnogenol, also 100 milligrams, was shown to significantly reduce the need for additional analgesics in patients that had dysmenorrhea. This is a study on fish oil and vitamin E. There were 4 groups, 1 given vitamin E, 1 given omega-3s, 1 given a combination of vitamin E and omega-3s, and then 1 that got placebo. Surprisingly, they only used 300 milligrams of fish oil, was 180 EPA, 120 DHA combined, and then the vitamin E was 200 IUs. So both separately, the vitamin E group and the omega-3 group showed significant reduction in pain over the placebo. Imagine what would happen if they gave more than 300 milligrams of fish oil. And then the combined vitamin E and omega-3 group showed even greater reduction over placebo. So for the vitamin B1 in fish oil study, it was 240 high school females with dysmenorrhea. They're divided into 2 groups, a placebo and then also a group that had a combination product of 100 milligrams of B1 and then 500 milligrams of fish oil. They took this daily for 2 months, and then after 2 months, their pain was reevaluated, and they had significant reduction in pain in the group that received the supplement versus placebo. And then lastly, we have a study on fish oil just in general. There was 2 groups. So one group was given an omega-3 capsule every day for 3 months, followed by 3 months without anything. They got the placebo. And then group 2 had the placebo for 3 months, and then they were followed by 3 months with the fish oil. And then they were also given an option to do 400 milligrams of ibuprofen rescue dose. And basically this study found that, while the patients were on fish oils, they needed to use the rescue dose to decrease their menstrual pain much more. And then here's just a sample treatment plan. Lots of things that I've kind of already gone over, but you could do an anti-inflammatory diet, limit red meat, or switch to grass-fed, start them on fish, lifestyle, incorporate aerobic exercise, definitely work on stress reduction. You could do acute botanical formula, and then I also, here's a product that has a lot of the herbs that I mentioned in it, if the patients can't tolerate taking the tincture. And then long-term, definitely consider high-quality fish oils, pelvic tonics, and then give it about 3 months to reevaluate if you're doing these long-term formulas versus the acute dosing of the botanical tincture. You definitely should be able to know after they try it out that first time if it's going to be effective for them or if you need to change it. Here's some other considerations to definitely consider. progesterone therapy. They might be low in progesterone, and that's contributing to their menstrual pain. Myonular massage, e-stim over the pelvis actually has a lot of good research, as well as acupuncture. That concludes the end of my talk. You can reach me here if you have any further questions.
Awesome. Thank you so much, Dr. Williams. That was beautiful. Up next, we have Dr. Rodriguez, because it looks like that we did not have any type of questions. Just to kind of keep all of our viewers updated, you guys can go ahead and submit the questions via chat. It is going to be in the Zoom bar that you can go ahead and just hit chat or raise your hand, and we're going to go ahead and try to get to those questions again directly after the presentation. But up next, we have Dr. Rodriguez. Dr. Rodriguez, want to go ahead and say hi?
Good morning, everyone.
Morning. All right, we're going to go ahead and get started with your presentation. And we'll go ahead and dive right in. Again, if you guys have any questions, please just feel free to ask, and we'll go ahead and address those right after the presentation. Otherwise, I'm going to hand it over to you.
Good morning, everyone. So I'm Arianna Rodriguez. I'm a second year, almost completing my second year of residency at SCNM. And I've been primarily focusing on dermatology and treating dermatological conditions. So today I'm actually going to be talking about the treatment of acne, a really common skin condition, and what nutritional interventions I use and kind of the research on nutritional interventions for the treatment of acne. So first I'm going to talk about the epidemiology and kind of the prevalence of acne, as well as the pathophysiology, so how acne actually develops, in order to be able to really understand what treatments are being used in acne and why. I think it's important to understand the pathophysiology of how acne actually occurs. Then I'm going to get into some diet recommendations, the use of probiotics. I'm actually going to talk a little bit about the use of fish oil supplementation, fatty acid supplementation, as well as vitamin D. Acne is one of the most common skin conditions in the world. It affects more than 80% of adolescents, and then will commonly continue to affect people into adulthood. In the world, it's actually the 8th most prevalent disease, not just dermatological condition, but disease in the world. During puberty, acne tends to affect males more than females. And then, interestingly enough, as you approach adulthood and into adulthood, females tend to be more affected, affecting up to about 12% of females will have reported post-adolescent acne. So now I'm going to talk a little bit about the pathogenesis of acne and exactly how acne develops in the skin. So one of the first things that you have is overproduction of keratin within the folliculosebaceous unit. So I apologize for my graphic. It has a few typos that I didn't make, but they were on there. So this should actually say sebaceous gland, and then it says accumulation of epithelial cells of keratin, so that's spelled incorrectly. But anyways, the graphic is just kind of a depiction of the folliculosebaceous unit where acne develops. So within the follicle, you get an overproduction of keratin, and those keratin, that retention of keratinocytes leads to this keratin plug and the formation of the microcomedo, which is the original acne lesion, is the microcomedo. So once that keratin plug is formed, excess sebum production is also seen. So these sebaceous glands within the folliculosebaceous unit start producing too much sebum, and that creates the perfect anaerobic environment for bacterial proliferation. So Propionibacterium, used to be referred to as Propionibacterium, now it's Cutibacterium acnes, is the bacteria that's commonly associated with the development of acne. And the proliferation of that and colonization of the folliculosebaceous unit usually triggers this inflammatory cascade that leads to the other thing, to the inflammatory component of acne. So you have Cutibacterium acnes proliferating within the folliculosebaceous unit. At some point, there's so much proliferation, the folliculosebaceous unit ruptures. This then leads to inflammation. You see neutrophils, macrophages, natural killer cells, dendritic cells, Langerhans cells, a lot of large immune response that happens within the folliculosebaceous unit, and that creates these inflammatory lesions that we see in acne. We know that androgens such as DHEA and DHT are hormones that are involved in the synthesis of sebum. So DHEA and DHT regulate some of the content within the lipids, within the production of sebum, and that is part of the inflammatory process that we see. Sebaceous glands also, another not new finding, but another new avenue of treatment for acne is now stress modification, because we know that sebaceous glands also express receptors for neuroendocrine mediators that are related to stress, and we know that stress can also lead to an increase in sebum production, which can make acne worse. We also know that psychological stress can induce slower wound healing times and make it more difficult for us to repair active acne lesions. So stress has kind of a dual role in the pathogenesis of acne. So now that I've discussed kind of how acne forms, I want to talk a little bit about the different features of acne and the different lesions that you see in acne. So first you have comedones. There's closed comedones and open comedones. Closed comedones are commonly referred to as blackheads. They're formed by the accumulation of sebum and then this keratinous material in the follicle that kind of expands the follicular opening. And you see in the picture, you have kind of this blackhead formation that's known as a closed comedone. Then you have open comedones where the follicular opening continues to be distended, and you get what's known as whiteheads. I don't have a good picture of whiteheads there, but the open comedones are commonly referred to as whiteheads. Then you have inflammatory lesions. So once you continue to have that proliferation of the bacteria, stretching of the folliculosebaceous unit, that follicle will rupture, and you get this inflammatory response leading to these erythematous papules. So these are known as inflammatory lesions. As you can see in this photo here, this person has a lot of inflammatory lesions on his back. They're kind of these erythematous papules that are considered a hallmark feature of acne. You also get the development of pustules. So pustules are these inflammatory papules that actually contain purulent material, and they sit on an erythematous base. As you can see in this photo, this person has kind of a larger pustule on his cheek. And then you have nodules. So nodules are these larger, deeper inflammatory lesions that are tender to palpation. They're usually larger than about 5 millimeters, so larger than half a centimeter. And these are seen usually in more severe forms of acne where people actually develop these painful nodular lesions. So when you have your acne patients and you're trying to decide what treatments you want to try with them, what dictates that a lot is the severity of the disease. So disease severity is usually can be difficult to assess, as there's a lot of things that you have to consider. Usually what's taken into consideration when kind of trying to classify someone's acne is the number of lesions that they have, whether or not they have inflammatory lesions. So are there only open and closed comedones and not really any erythematous papules, or is there a lot of inflammatory lesions, erythematous papules, and these painful nodular lesions? The presence of painful nodular lesions is another sign of more severe acne. Quality of life impairment. So the presence of comorbidities such as anxiety and depression. A lot of people can find acne to be very distressing, whether the severity on their face directly correlates to that. Sometimes even just a few lesions can be really distressing to your patient. So it's definitely something that you have to take into consideration when classifying someone's acne, is how much their life is being affected by this condition. If they're self-conscious, and if this is leading to the development of other conditions such as anxiety and depression. And this is why we as naturopaths, we take a more holistic approach to this, and we take into consideration how this is affecting people's lives. Okay, so now I'm going to discuss the role of dietary interventions and kind of what my go-tos are as far as nutritional interventions when I'm treating a patient with acne. So in working with some dermatologists, has been kind of this battle of ideas versus, does diet have anything to do with the development of acne or not? And I've had people say to me, unless you're taking that pizza that they're eating and they're rubbing it on their face, diet doesn't actually have anything to do with acne. And so in 2002, there was this great study that was published that really kind of led to this paradigm shift where dermatologists started accepting the fact that maybe our diet does play a role into the development of acne. So there was a study by Cordain that noted the low prevalence of acne in non-westernized populations. So they went to New Guinea and to Paraguay, and they noticed that there was no acne. Even amongst adolescents that are at higher risk of developing acne, they couldn't find a single acne lesion when they were doing the study. So further investigation, when they kind of looked into why these people don't have any acne lesions, revealed that their diets were comprised of really low glycemic load foods. They eat very low amounts of processed foods, and their diets were really rich in whole grains foods, fresh fruits and vegetables, and fish. So glycemic index is kind of a relative ranking of carbohydrates in foods, and it's according to how they affect blood glucose levels and subsequently insulin levels. So the glycemic load of a food is calculated by multiplying the glycemic index by the amount of carbohydrate content in 100-gram portions of that food. So in 2012, after a while after this study by Cordain came out, this other study came out that was actually demonstrated that patients who followed a low glycemic load diet experienced reductions in the sebaceous gland size and decreased inflammation in their acne lesions. So this is a study that was done on Korean patients that were prescribed a low glycemic load diet, and when they looked at their lesions after they had initiated these diets, histopathologically they actually saw a decrease in their sebaceous gland size and a decrease in inflammation in the follicular sebaceous units. Another food that is a little bit higher in glycemic load that has been associated with acne is milk. So dairy has been shown, specifically milk consumption has been shown to induce hyperinsulinemia, insulin resistance, and a raise in serum IGF-1 levels in both children and adults. And these IGF-1, so these levels are actually thought to also increase sebum production. And as we saw, that an increase in sebum production then allows for more colonization of the Cutibacterium, leading to more inflammation and the rupture of the follicular sebaceous units. Okay. So then I want to talk a little bit about omega-3 consumption and supplementing fish oil and why we do that. So there was a great, actually randomized controlled trial in which participants with mild to moderate acne were dosed with 2,000 milligrams of EPA and DHA. And in this study, they saw a significant decrease in the number of inflammatory lesions and in severity of disease by the group who received daily doses of omega-3 fatty acids. So this is another nutritional intervention that kind of supports decreasing inflammation within the body and hopefully decreasing the inflammation found in your patient's acne lesions. Then probiotics. Probiotics are becoming a really interesting field. There's a lot of research going into it, a lot of new research, some things that haven't been published yet. But this study specifically has shown that Lactobacillus paraceci, this specific strain of it, can be beneficial in processes associated with barrier function and skin reactivity, so helping your patients heal their acne lesions after the fact. There is also a study that hasn't been published yet that showed that people that were treated with antibiotics, whose acne were treated with antibiotics, had improved results when a probiotic was added in addition to the antibiotic. So at the very least, when your patients are on antibiotics for their acne treatment, adding a probiotic has been shown to have more beneficial effects as well. Then there's vitamin D. Vitamin D is a common supplement that we think of in most skin conditions. There have been a lot of conflicting studies showing that, maybe vitamin D is helpful, maybe it's not helpful. It can have antimicrobial effects, and it can and it has been shown to have an immune regulatory function on sebocytes to hopefully help decrease some of that inflammation that occurs that we see in acne lesions. However, there was one study that showed that vitamin D deficiency was found to be more frequent in patients with acne, and that the more severe that their presentation was is actually inversely correlated with their vitamin D levels. So the more severe their acne presentation was, the lower vitamin D levels that they had. So that kind of wraps up my presentation. These are just a couple of dietary interventions that I wanted to discuss that I commonly use in the treatment of acne. Usually my go-to as a naturopath is a combination of using botanicals, dietary interventions, as well as lifestyle and stress management. But I wanted to talk specifically about some nutritional interventions that you can use for your patients.
Awesome. Well, thank you so much, Dr. Rodriguez. You are amazing for addressing some of those topics. Really, really interesting, because I remember in high school, I mean, I definitely suffered from acne myself, and it really did kind of play on my self-esteem. So very interesting. Up next, we have Dr. Tapia. Super exciting. We're going to go ahead and talk about that.
All right, give me a minute to get situated.
All right. Now, Dr. Tapia, if you want to go ahead and maybe introduce yourself, maybe talk a little bit about some of the topics we're going to be talking and discussing about today.
Sure. Hello, everyone. My name is Dr. Tapia. I am finishing up my second year residency here at SCNM. Today, we're going to be discussing treatment of severe atopic dermatitis with homeopathic medicine. All right, so some of the goals for this talk is going to be discussing the prevalence and clinical presentation of atopic dermatitis, conventional treatment and prognosis for the disease, and then the Eczema Area and Severity Index, which is an awesome tool that we as physicians have to assess the extent and severity of atopic dermatitis, and then the use of homeopathic medicine in the treatment of atopic dermatitis. All right, so let's get started. So what is atopic dermatitis? Atopic dermatitis is commonly referred to as eczema or atopic eczema. It's a chronic pruritic inflammatory disease with often relapsing symptoms. It most frequently occurs in children, but adults are also affected. 5 to 20% of children are affected worldwide, and typical onset is before the age of 5. Common signs and symptoms for atopic dermatitis are pruritus, xerosis, erythema, oozing, crusting, and lichenification. Depending on the severity of the disease, atopic dermatitis is a clinical diagnosis based on history, morphology, and the distribution of skin lesions. Typically, it involves the flexor surfaces, so like your inner elbows, the back of your knees. For our patient, it involved several other regions since he had severe atopic dermatitis, and presentation is variable depending on the severity of the disease. All right, so we're going to jump into conventional treatment and prognosis. So the goal of conventional treatment is to reduce symptoms and prevent exacerbation. It's not curative, but can be very helpful in managing the skin inflammation and pruritus. First-line therapy includes the use of emollients, so substances that help keep the skin moist by reducing water loss, so typically found in various creams and lotions. Topical steroids are often used in conjunction with emollients to help combat the eczema symptoms. Other therapies, depending on the severity of the disease, include phototherapy, oral steroids, and immunomodulators. Treatment is not without side effects, though, and common side effects specifically for corticosteroids include skin atrophy and the skin becoming resistant to the steroid, requiring higher potencies to be used, specifically for topical steroids. Also, oral steroids suppress the immune system, cause weight gain, and the disease can quickly relapse once the medication is discontinued, which happened specifically in our patient's case. Prognosis is variable and depends on the level of disease activity. One study found that persistent or frequently relapsing dermatitis occurred in about 77 to 91% of those suffering with severe and moderate dermatitis during their teen years. All right, so a little bit about our case. So we had a 10-year-old male present to the clinic with severe atopic dermatitis affecting the trunk, upper extremities, lower extremities, and sacral region. The patient had a 4-year history of managing atopic dermatitis with conventional treatment, but had poor results. The patient was evaluated by several different dermatologists and allergists, and finally Mayo Clinic. Mom informed us that Mayo Clinic reported that this was actually the worst case of eczema they had ever seen. Mom stated that the patient was screaming daily for hours and scratching incessantly. All right, so prior to seeing us, they obviously had tried several treatments. Before starting homeopathy, they were using several emollients, which Mom said took about 40 minutes to apply each morning and night. Topical steroids and oral steroids provided temporary relief, but as soon as the medication was discontinued or any portion of the regime stopped, he was worse, back to square one. Throughout the 4 years, Mom had tried all the conventional treatments and also had tried various bleach baths, oatmeal baths, essential oils, but nothing with lasting results. And in May 2016, as mentioned, a month prior to seeing Dr. Messer, the patient was evaluated by Mayo Clinic, and they were actually recommending the same protocols that they had been using over the 4 years. And so a friend of recommended that they try homeopathy. All right, so before we jump into homeopathic results, I do want to discuss the Eczema Area and Severity Index, which is a great tool that we as physicians have to measure the extent and severity of eczema, and it's great for tracking the progress of improvement. So I'm going to kind of walk you through this step. So on the right hand of the screen, you're going to see a nice graphic walking you through the steps, and if you just Google like eczema scoring, this PDF will come up, and then I also referenced it for you below. So basically, they split the body up in 4 different sections. So the head and neck, the upper extremities, the trunk, and the lower extremities. And each section has a potential of 100% eczema involvement. So once you select the body area, you assess the extent of eczema using a score of 0 to 6, 0 being no involvement, and then 6 being 90 to 100% involvement. So that's how you assess the extent. And then for the severity, there are 4 different markers that are used, specifically assessing erythema, edema, excoriation, and lichenification. And there's a great a little severity atlas that you can use to reference. So each of the markers has a range of 0 to 3, 0 being no involvement, and then 3 being severe involvement. And then once you have all your data points, you plug it into the table, and there's actually 2 tables, one for if the patient is 8 years or older, and the other if they're under 8 years old, and that's because there's specific multipliers that are used to take into account the proportions of the body in a younger individual. And so you have a potential total score of 0 to 72. And so that's an awesome tool that you can use, and obviously taking photos is fantastic as well. For our patient in particular, Mom took several pictures throughout the course of treatment, and specifically 3 regions were selected based on the consistency of data. The 3 regions that we selected were the back, the thighs, and the sacral region. the sacral region being the region that was most severely affected by eczema. And then we used 3 specific markers to assess the severity. We used erythema, edema, and excoriation. And so there was a potential, each of them obviously have a total score or potential score of 3 for each section, so potential total score of 9 for a combined score. And so if the patient was seen that month more than once, the scores were combined. And we specifically tracked, as I mentioned, those 3 markers, and the pictures were chosen closest to the encounter date, so when they came in for the visit. All right, so let's talk a little bit about homeopathic treatments and the results. So before we jump into that, I do want to talk a little bit about homeopathy. So homeopathy was developed in the 18th century by German physician Samuel Hahnemann. It's a form of medicine that uses the law of similars, so like cures like. The greater the degree of similarity between the homeopathic medicine that is produced, the greater the degree of similarity between the symptoms produced by the homeopathic medicine to the symptoms displayed by the individual, the more likely it's going to trigger the body to self-heal. So that's our goal with homeopathy. And there's several studies that are out there showing the efficacy of homeopathic treatment in chronic skin diseases. One study specifically showed the effects of homeopathic treatment in 60 Japanese patients with chronic diseases. The chronic diseases were atopic dermatitis, severe acne, chronic urticaria, and psoriasis. All the patients had actually been treated conventionally, but only had partial response to treatment. And so they used individualized homeopathic treatment, and a total of 88% of the patients had over 50% improvement in their skin condition with individualized homeopathic care, which is really awesome. And some studies, I definitely listed some studies for you to look into at the end of the slide. All right. So the first graph here, we have the back eczema in red. So we have on the x-axis, we have the months. So month 1 being the initial visit. And then the y-axis has the severity score with a potential score of highest score of 9. And then above is actually the homeopathic remedies that were given at that visit. So month 1, they had actually started homeopathy. They had started sulfur 30C prior to seeing us, and they were doing really well. Mom said that the patient had significantly improved pruritus, was scratching and screaming less, so they were doing well, so they were kept on that remedy. By the 2nd month, symptoms were a little bit worse, but they were doing well. The remedy was still indicated, so we went up in potency. And then as you can see, when they presented at month 3, the severity score still had increased, so we reanalyzed that case and prescribed Rus-Tox 30C, and then we can see following that there is significant decrease in the severity score with resolution of the back eczema by month 6. And I'll show you guys photos as well. So here we have month 3. As we know, it was the back eczema was most severe, so we see significant erythema, some edema, and then month 5 significantly improved, and then obviously month 7 completely resolved, which is fantastic. So specifically Rus-Tox was chosen because at that specific time the patient had a significant pruritus. He was scratching until raw, and then he had this interesting clear fluid discharge that would be happening at night. And as we can see in Allen's Encyclopedia of Materia Medica, it covers his symptoms really well. So severe, almost intolerable itching, vesicular rash, itching, burning terribly, and then we see that clear fluid that patient discharge, which matches this remedy really well. All right, so next up we have the thigh eczema now in red, and the back eczema is in gray now. So as you can see, the thigh eczema follows a similar trend to that of the back eczema. And so, the patient was initially on sulfur, then Rus-Tox, And then, as you can see, when he was prescribed Staphysagria, there was significant improvement in severity score beyond baseline. And so let me show you the pictures for that. So here we have month 1. The thigh eczema, isn't too severe. And then month 3, you can see that definitely the severity score had increased, so we can definitely see that. Month 7, significant improvement. By this time, he was on Staphysagria, and then mom stopped taking photos because he was doing great. So we have month 26, there was obviously complete resolution of the thigh eczema, and so at that particular time, Staphysagria was prescribed because his mood actually had significantly shifted. He was very irritable and angry. And then he obviously still had the eczema, and so Staphysagria covered his mood really well and the eczema lesions. And so as we can see in Allen's encyclopedia, very peevish, eruptions, eruptions are itchy, and when scratched are moist, so it still covered the discharge, and then indignation with vexation. And so following Staphysagria, the patient was emotionally better, and the eczema had continued to improve, which we love to see, because with homeopathy, we're not looking at just the symptoms, but we're looking at the individual as a person. So their mood, everything that's going on, what is going on, so that we can prescribe the best remedy at that indicated time. All right, so moving on. So lastly, as I mentioned, the sacral region was the one that was most severely affected. So the severity score was pretty high, 8 to 9 for the good, first 12 months of treatment. So we have the sacral in red, the thigh eczema is in green, and the back eczema is in gray. So here you can see that there really, wasn't significant improvement until about month 15, when Mizerum was prescribed. So at that point, he had significantly copious discharge, which is well covered by that remedy. And so we see once Mizerum was prescribed, we see significant improvement beyond baseline, and then continued improvement. So here are the photos for the eczema. Obviously, the sacral region was most severely affected, so there's a lot of erythema, edema, and excoriation present. So we can see here the first 10 months is pretty severe, and then by month 15, the patient is on Mizerum, and so we can see continued improvement and then resolution by month 26, so about over 2 years of treatment, but eczema is completely resolved, and the sacral region was actually the last region to clear up. And so here were some of the rubrics that were used. So the eczema in the lumbar sacral region, it definitely moist, and he had copious discharge in that region, where the patient actually had to change the undergarments a few times a day sometimes, because it would be fully saturated with the discharge, and he was aggravated with bathing. And so here we can see in Allen's encyclopedia that it covered his lesions really well. Red, itchy rash, very distressing, violent itching with that copious xerous exudation, which matched him really well. And so he continued improving on this remedy, and then symptoms completely resolved by month 26. All right, how are we doing on time? Good? All right, and so so the organon of medicine is basically the principles of homeopathic medicine laid out by Samuel Hahnemann. Aphorism 171 specifically talks about that chronic diseases need several homeopathic medicines are often needed to be used in succession to bring about a cure. The medicine chosen is based on the current symptoms left after the previous homeopathic medicine has completed its action. And in this case in particular, we see the chronic eczema the patient had 4 years prior, needed several remedies to be used in conjunction to bring about a curative effect. So this is awesome to see, and we're bringing one of the aphorisms of Dr. Samuel Hahnemann to life, which is pretty awesome. All right. So this concludes my talk, and thank you guys for listening to us today.
Thank you so much, Tapia, Dr. Tapia. If you want to go ahead and, as you said, this is some of your references as well. But yeah, up next, it looks like we have Dr. Salisbury, which should be talking about some pretty cool topics as well. But thank you so much, Doctor. All right. Well, Dr. Salisbury, if you want to go ahead and just introduce yourself along with some of the topics that we're going to probably be talking about today.
All right. So my name is Dr. Salisbury. I'm a current third-year chief resident, about to finish up in the next couple weeks. And today I'll be talking about endometriosis and using lots of different naturopathic treatments for that.
Awesome. Perfect.
All right, so in this talk, you're going to learn about different allopathic treatments to treat endometriosis, along with using different botanicals, Chinese medicine, and homeopathy. So for those of us in practice, this is a pretty regular thing that we see. It's a very common condition of women of reproductive age. So in the US, about 6.5 million women are believed to have it, so it's about 1 in 10 women. 10% of all reproductive age women are believed to have it globally. So it's caused by ectopic endometrial cells implanting, growing, and eliciting an inflammatory response outside of the uterus. So that was a very long statement. And what that basically means is that portions of the uterine lining kind of migrate out of the uterus and adhere to different places in the body. Nobody really knows why this happens. There's a lot of different theories as to why this happens. A lot of people think it could be due to changes in the pelvic's immune response, their ability to surveil and remove things that they need to remove. Also could just be a genetic cause, could be an issue with cell apoptosis, so cells not dying the way they should. There's lots of different reasons. The biggest theory now is this idea called Sampson's theory, which is retrograde menstruation. So basically this means that they believe that what ends up happening is endometrial cells end up flowing backwards through the fallopian tubes and into the peritoneal cavity during menses, which causes adhesions. So most often endometriosis is found on the ovaries, the anterior and posterior cul-de-sac, different ligaments that hold the uterus up, so the posterior broad ligaments, the uterosacral ligaments, the uterus itself, fallopian tubes, the colon, appendix, round ligaments. They can also have deep infiltrating endometriosis, which you can find in the rectum. Other causes are their superficial lesions or their peritoneal lesions. On the ovaries, we call any endometriosis found there an endometrioma. So the symptoms of endometriosis are variable. So your patient can present with all of these or maybe only a couple. So the most common one is dysmenorrhea. So they describe the pain as either dull, throbbing, sharp. It could be a combination, it could be all of them. It kind of just depends on the patient. I've also heard patients say it feels like there's a hot knife going across their pelvic region, lots of different feelings. And most of the time, the pain is located wherever the adhesions are. So it might be more one-sided. If they have it on both sides of the pelvic cavity, then it's going to be bilateral. They also suffer from menorrhagia because you have to think these adhesions are shedding every month. So those things are shedding as well. So that's more blood loss. Women that have that deep infiltrating endometriosis also complain about dyspareunia, which is pain with intercourse. And they'll describe that pain as being a very deep pain with intercourse. They can also have diarrhea, constipation, difficulty with the bowel movement, cramping, nausea, vomiting, bloating. The bladder can be affected just because of where it's located. Sometimes they'll have abnormal uterine bleeding, meaning they might spot between periods, so always need to investigate that. Low back pain, they can have chronic fatigue, and then endometriosis is tied to infertility. And so sometimes your patients might have a couple of these symptoms, like I said, or they might have them all. Sometimes they're daily pain, sometimes it's pain a couple days before they start their menstrual cycle, sometimes it's only during the menstrual cycle. So everyone's just really variable on how they present. So in order to diagnose endometriosis, you can do different imaging, but it is not the gold standard of diagnosis. The diagnostic criteria really is a laparoscopic procedure, so it's a pretty invasive diagnosis. That being said, you typically can see some endometriomas on ultrasounds. You can see them also on pelvic MRIs, but to be 100% positive, you need to have a laparoscopic procedure. And this is because most of the time the adhesions are so small, you can barely see them, so most imaging won't pick that up. There's also no labs to diagnose this, so once again, that diagnosis really does result on that laparoscopic procedure. Once diagnosed, and I have to just say that it takes typically about 7 to 10 years from the start of symptoms until they're actually diagnosed to receive that diagnosis, they stage kind of where the patient is. So a stage 1 means that there's almost really no disease that they can find, no implants, no real adhesions. Stage 2 is mild endometriosis, so very superficial implantations. They're not bigger than about 5 centimeters. They can be scattered in the peritoneum and the ovaries. Stage 3 is a little bit more moderate. So that's going to be multiple implantations. They're going to have superficial and deeply invasive ones. And then there's also going to be some possible adhesions on the ovaries as well. Stage 4, it's a severe disease, and it's characterized by multiple superficial and deep implantations. And these are typically larger ovarian endometriomas. So if you look at this graphic, graphic number D, or letter D, I should say, that would be an example of what stage 4 endometriosis would be with that endometrioma on the ovary. So the staging of the endometriosis does not actually correlate with the amount of pain the patient might have. So you can have stage 1 endometriosis and have daily chronic pain. You can have stage 4 and never even know it. Sometimes women find out they have endometriosis because they're having a laparoscopic procedure for something else, and then it's just found incidentally. So the treatments that are typically used allopathically are NSAIDs, so just really trying to control that inflammation and that pain. Another treatment that is tried is oral contraceptives, and so what ends up happening is they're given low progestin over-the-counter or oral contraceptives, and the thought is to modulate the hormones, and so by modulating the hormones, then we can reduce the pain and possibly the menorrhagia that's there. If a woman has very severe endometriosis, I've seen this done multiple times. They just let the woman never have a menstrual cycle. So she just skips that last week of placebo pills and starts a new pack. That's pretty common if it's a really severe disease and they're in constant pain all the time. Women also will be prescribed IUDs. So a lot of the time Mirena to help modulate those hormones as well. And then the newest biggest thing is these GnRH analogs. So they're drugs like Lupron, which work by decreasing the amount of LH and FSH, so then they suppress the ovarian follicular growth. So the woman is put in a chemical menopause. So you have to think most of these women are in their late 20s to early 30s, and they're being put into chemical menopause. So they experience the symptoms the same as a woman does in menopause. So hot flashes, weight gain, hair loss, mood changes. They will have a loss of bone density because once again, they are in menopause, which is those are all very common things we see. One of the newest drugs is called Orlissa, which is a daily GnRH analog, and that was just, I think, approved last year by the FDA for the use of endometriosis. So it does the same thing as other GnRH analogs like Lupron do, except you just take the pill daily. Right now, the Lupron, it's just, you go in monthly for an injection, you do it for 6 months, and then the menstrual cycle comes back hopefully in the next 2 to 3 months after they stop. And the hope with those treatments is that by shutting all that off, then you're shutting off the growth of the adhesions, and the woman really has relief from pain. And it is helpful for about 80% of women. It does relieve pain for about up to 5 years. However, that pain can come back, and it's not effective for that 20%. Typically, when they go in to do the laparoscopic procedure, they'll go ahead and just remove the adhesions, and that's pretty common too, to just remove some of that pain. And then if they fail all treatments, then they recommend a hysterectomy, so removing the uterus and the ovaries and most likely the cervix. All right, so let's chat about the patient that we're going to chat about today. So she is a 30-year-old female, and she was diagnosed in 2004 after having a left oophorectomy to remove a dermoid cyst. So her dermoid cyst actually had teeth and hair in it, and after they removed this, they found that she actually had stage 4 endometriosis, and it was located mostly on her bowels and her bladder. Since 2004, she had about 7 to 8 laparoscopic surgeries. Her last one was in August of 2017. And the more times you do a laparoscopic surgery, you increase your risk of getting abdominal adhesions just from opening up the abdominal cavity. So she does have abdominal adhesions as well. She has a constant daily pain from about a 6 out of 10 to ranging to 8 to 9 out of 10. So her endometriosis pain is daily. Her pain is worsened with stress, and it's so severe that it can wake her up from sleep. She also has dyspareunia, and her menstrual cycle was very, very long. So she would bleed for 7 to 10 days. 5 days were heavy, so she would use between 10 to 12 super tampons on those days. And then for her lighter flow for 2 days was using 5 to 6 super tampons. So still a very heavy flow. She experienced all of these symptoms during her menstrual cycle and during PMS as well. So diarrhea, bloating, food cravings, increased sensitivity and weepiness, headaches, menstrual cramping, fatigue, backache, and breast tenderness. She also had pain with defecation due to the endometriosis, and she would have pain and soreness in the rectum before, during, and after a bowel movement, which required her to sit on a heating pad to alleviate the pain. And she would have 2 bowel movements a day, so that pain with defecation was daily. She also had very light menstrual blood that would come out every day, so she had some of that abnormal uterine bleeding as well. So that would soak through about 1 regular pad a day. So she tried Lupron for about 6 months, and she had a lot of the side effects that I mentioned. So she gained a large amount of weight. She had a difficult time losing it. Her mood changed. She went through chemical menopause. In August of 2018, she had a Mirena placed, and she had, uterine bleeding before the placement of Mirena, which continued after the placement of Mirena, and it worsened slightly. She also takes daily ibuprofen. She takes about 800 milligrams every 4 hours at work. So, the max is 3,200. So she would continue that throughout the day, not just for work if she needed to. So she was getting close to that max dose. She also self-prescribed for herself yarrow flower tea, which she started 2 weeks before seeing me, which she said helped with some of that blood loss. And then she started N-acetylcysteine as well, pine bark, probiotics, and she tried some dietary changes, like incorporating more fruits and vegetables. She also carries a past history of interstitial cystitis and IBS, which I think are both important because there's so much pelvic crosstalk between the uterus and the rest of the abdominal cavity in that area. So she does carry a diagnosis of IBS and interstitial cystitis. That interstitial cystitis, for her symptoms are urinary frequency and urinary retention, mostly due to the fact that the endometriosis is on her bladder. And then the IBS, just because the difficulty with defecation, and then all the adhesions on the bowels themselves. So she was a very, very motivated patient. So we did a lot of things for her. She wanted to get out of pain, and I wanted to help as best I could. So our goal for her was to reduce her inflammation and pain. So we started off with a diet diary for a week just to see what she was eating. Then we moved on to different supplementation. So the first one was Vitanica Slow Flow. We gave 1 capsule 2 times a day for 2 weeks, and we decreased her to 1 capsule once a day. We also prescribed a fish oil, 1 tablespoon per day, Super EFA Plus with food. I also recommended biotherapeutic drainage, so UNDA products, which I'll talk about all these things in detail in a minute. So UNDA's 10, 20, 2, 45, and she did 5 drops 3 times a day on the tongue. Then we also recommended Vitanica's Cramp Arc Extra, 2 capsules every 4 hours. We also recommended Simisafuga homeopathically, 30C, 3 pellets under the tongue once a day. We increased her N-acetylcysteine or NAC to 1 capsule 3 times a day. And then I increased her pine bark to 2 capsules 3 times per day, which gave her a total of 900 milligrams, which is a very high dose, but we'll talk a little bit about it in a second. I also recommend acupuncture for my patients because I just believe it's helpful overall for their concerns. And then due to her bleeding, we also ran basic blood work, a CBC, a CMP to look at her liver function, her iron panel, and a food allergy panel to see if there are foods causing any more inflammation for her. So the first supplement that I recommended was Vitanica Slow Flow. And the reason that I recommended it was because of all the different botanicals in it along with some of the nutrients. So vitamin A, C, and vitamin C and bioflavonoids, they're shown to help support basic healthy menstrual flow. Vitamin K can help with clotting. Achillea, which is that yarrow tea she was drinking, which we actually had her stop when we initiated treatment, is a styptic herb, so it's going to help stop bleeding. It's a spasmolytic, which is going to help with some of that cramping, and then it's going to stringe the uterus. Geranium is also another herb that's in that formula, so it's also an astringing and a styptic herb. Capsella bursa is also astringing and a styptic, and then zingiber for its spasmolytic and inflammation modulating properties. We also recommended Cramp Arc Extra for her, so it has vitamin B3 or niacin to help with the uterus response during a menstrual cycle, vitamin C and rutin to help with the niacin, calcium and magnesium to offer some musculoskeletal relaxation, vitamin B6 to help with relaxation, vitamin E to help with that uterine tissue, and then valerian root to help kind of calm her down. So it's a sedative, an anodyne, and a spasmolytic. Viburnum is also a spasmolytic and astringing herb. I gave her the actual botanical of Simisafuga as well, so spasmolytic and inflammation modulator. It's an analgesic and a nervine and an anodyne. And then the zingiber is in this product as well for the same reasons. I also gave the pine bark. So the reason I gave such a high dose is because given her history with all of the laparoscopic surgeries, I really wanted to go after all of those free radicals that she most likely has. So it's such a strong antioxidant and it's very safe. So we recommended that. And then the N-acetylcysteine, which is a precursor to glutathione, which we know helps in detoxification. It's another great antioxidant. So we gave her that as well. And then Super EFA Plus, which helps reduce inflammation. And then the plant sterols and their help to modulate the immune system. So I also gave her a homeopathic remedy. So Simisafuga 30C, and like Dr. Tapia spoke about homeopathy, it's the idea of like cures like. So I prescribed this based on her severe bearing down pains, feeling as if something were to pass out. She mentioned multiple times in her intake that she felt like she had to scoop up her uterus, labor-like pains for the cramping, the severe pain in the lower abdomen, those exhausting menses, and the spasms of the broad ligaments. I also use a different form of homeopathic products called biotherapeutic drainage, specifically UNDA therapy. And so UNDAs are composed of a plant, metal, and mineral to detox at the cellular level. I've seen these work really well for lots of chronic disease. Really for endometriosis, it seems to work very well. So I picked the numbers 10, 20, and 245. 10 is indicated for the female endocrine system and for dysmenorrhea. 20 helps to detox the liver and used in chronic disease. 245 is indicated specifically for the uterus and the ovaries, any adhesion, any cyst, if anyone has menorrhagia. So the different homeopathically prepared plants, minerals, and metals that are in these products. So for Unda number 10, we have wormwood, Argentum metallicum, equisetum, juniperus, and achillea again. Then in Unda 20, we have aluminum metallicum, Argentum metallicum, and calendula. And then in Unda 245, we have rhubarb and viburnum. So you can see a lot of these products, or a lot of the same botanicals, are used over and over again, just very helpful. We did about 3 treatments of acupuncture with her. So we diagnosed her with a liver blood deficiency, with spleen qi deficiency, and liver qi stagnation. Acupuncture in Chinese medicine has been around for about 3,000 years. These are pretty common diagnoses for women with menstrual irregularities. So our goal was to nourish her blood, tonify her spleen, and soothe her liver qi. So I practice acupuncture slightly differently than a lot of the practitioners here at SCNM. I do a little bit more of what we call channel theory. So it's just a little different, utilizing 5-element and traditional Chinese medicine. So these are the points that were chosen. So spleen 1 through 5 were chosen specifically to help tonify her because she was so depleted. So spleen 1 is for Minaraja, spleen 2 helps to support the spleen, along with spleen 3, it's the source point of the spleen, meaning that it has all the energy for the spleen to be able to transform and transport different things in the body. Spleen 4 is used to what we call regulate the Qigong, and the Qigong is our sea of blood. For someone who's bleeding as much as she is, we really want to regulate that. And then spleen 5 to drain some damp. Sanjiao channel is used to help regulate the 3 burners in the body, so a lot of water metabolism. So we use Sanjiao 2 to relieve pain, Sanjiao 3 to clear the channel, and Sanjiao 6 to remove obstruction. Oops. We also used, I used the gallbladder to actually treat the liver. So I used gallbladder 40 to spread liver qi, 41 to open what we call the daimai, which is the pelvic girdle, and then gallbladder 44 to calm the spirit. And then due to her being so sensitive to stress, I wanted to help calm her spirit, or her shen. So those heart points, heart 3, 5, and 9 are also used for that. So now we're on to her follow-up. So 2 weeks after her follow-up, she was completely compliant with the treatment plan. She was pain-free for 5 days. This was the first time she had been pain-free in months. The worst her pain got was about a 1 out of 10. She had eaten something, it aggravated her, and she got a little bit worse. 3 weeks after her follow-up, she had had only pain 3 times, rated that pain about a 5 to 6 out of 10, when it normally would have been about a 9 out of 10. 1 month after treatment began, she only had pain twice, and that intensity of that pain decreased as well. So she was hanging at about a 4 to 5 out of 10. We also started to have her eliminate her food sensitivities at that appointment. Then we didn't see her for a couple months, which is fine. And a 3-month follow-up, she came in and she had no endometriosis pain at all. So she went from having a daily pain of a 6 to 9 out of 10 to having pain at a 0 out of 10. She had continued with all the supplements that were recommended. The only thing she wasn't doing was getting the acupuncture, but everything else was still working for her. Her menstrual cycles are now 4 to 5 days, and she only spots during her menses and only uses light pads. So before, her menstrual cycles were 7 to 10 days and very heavy, and now they're 4 to 5 and very, very light. So this case represents that there are helpful ways to manage endometriosis, manage the symptoms of it. As naturopaths, we have lots of tools to help out. If this line of therapy didn't work for her, I had at least 5 or 6 other things that I could think of that would probably be helpful for her, and with women of endometriosis. I think that's about it.
Awesome. Well, thank you so much, Dr. Salisbury. So it does look like we have a couple of, or just one question for Dr. Tapia. It was a presentation or a question that came through kind of last minute, and really the question was if the patient was continuing to take some of these remedies to continue some of the the treatment. So I don't know, we do have Dr. Tapia here to kind of answer that question. So Dr. Tapia?
Yeah, so the patient actually was last seen in September of last year, and so they were on Mizoram, but they were doing well, and so some of the pruritus did come back a little bit in the sacral region, so they were prescribed a different remedy, and they were taking it as needed, and so I haven't reached out to the patient, but since they haven't followed up, we're assuming they are still doing well. So that was that patient. So
Okay, well, perfect. Thank you so much, Dr. Tapia.
all right.
Awesome. And then again, if anybody else has any other type of questions, please go ahead and actually just send us an email over to Dr. Williams at DRALLISON Williams.com. I'm going to go ahead and put everybody's email address as well in the chat box. That's why you guys can go ahead and send them an email if you guys have any other questions or concerns. Okay. But thank you guys so much for everything. It does look like we have one more question. It looks like it says, does the patient with endometriosis have to continue to take the treatments prescribed? And I totally butchered that.
So she actually still is. She was doing really well, and she actually went to Disneyland and got on a roller coaster and aggravated really badly. And she finally got that pelvic ultrasound because we were concerned about the marina moving possibly. Turns out she has a fibroid, so she's continuing with endometriosis treatment, and now we're just trying to work through this fibroid issue that she has as well. So she's still taking everything.
Awesome. Well, perfect, doctor. Again, if anybody else has any other questions, we can go ahead and send over those email boxes. I'm going to go ahead and put all of those email addresses up here for you guys. Other than that, thank you so much for tuning in. And again, we look forward to doing this very soon. So hope you guys have a good day. Bye.